Welcome to the Health Overview and Scrutiny Committee. I'm Ashley Kendrick, Democratic Services Officer. Before we start, I need to inform you that this meeting is being live streamed and recorded. Please also note that all remote participants are muted at the outset of the meeting and are only able to speak at the invitation of the chair. Please raise your virtual hand if you wish to speak, and then only unmute when the chair invites you to make your contribution. The chair may ask that you are muted if you do not participate in this way. In the absence of the chair and vice chair of the committee, the first item on the agenda will be the election of the chair for the duration of the meeting. Please can I ask if there are any nominations?
Peggy Muller.
Would you have a seconder?
Yeah, I'll second.
Are there any other nominations?
I've both had a kiss.
Do you have a seconder?
I'll second.
Okay, so all those, are there any other nominations? Okay, so all those in favour of Peggy Mullock, please show. And all those in favour of Heather Kidd, please show. Right, we have time.
Oh,
You are able to vote for yourself, Peggy.
I didn't realise.
Yes, you were able to vote for yourself.
Do it again.
We'll do that one again. All those in favour of Peggy Mullock, please show. 1, 2, 3, 5. And those in favour of Heather Kidd. 1, 2, 3, 4. Lovely. Thank you very much. And just to confirm, Peggy Mullock, if you would like to come and take the chair.
Ranking hands on long here. Can we start with apologies for absence? We have Tracy Hopper, who's substituted by Ruth Horton. Ruth. Jeff Elner, who's substituted by Roy Allcroft. Kate Halliday, who is substituted by Julia Buckley. No more. Do we have any disclosable interest? Minutes of the meeting held on the 29th of January. Everybody happy? Need to propose. Somebody propose them, please. Bernie, seconded. Gerald. We don't have any public questions and we don't have any member questions. So we've had a request to move item 8 now. Which is an update from the Health and Wellbeing Board to this point in the meeting. Who's coming forward?
Councillor Cecilia Motley, and she's on.
Okay, Councillor Cecilia Motley, are you listening?
So sorry, Chair. My line is not great, I'm afraid. So as long as you can hear me, that's absolutely fine.
See you.
Oh, you can see me. That's great. So I would just like to update members. I gather that you've all been sent a copy of the, as it were, the skeleton agenda for the latest Health and Wellbeing Board agenda, which was last week. It was a very full agenda. We were concentrating unusually, actually, because over the last few agenda sessions, we have been concentrating more on what's been going on in adult social care. This time we had a really in-depth session on children and young people and all aspects of the joint strategic needs assessment. And I think it's worth just touching on the fact that the joint strategic needs assessment is entering a rather interesting phase insofar as it is setting up its own place plans along exactly the same lines as the existing place plans. In other words, we've got 18 JSNAs hoping to get up and running. They're not all completely up and running at the moment because it's a big job, and the purpose of this is so that we can really get some granular information on people's health and well-being in all our areas of the county, and we can almost personalize it. So that means that it means that we can look for different solutions to different circumstances rather than having to take a blanket approach. And we do a lot of work on this Joint Strategic Needs Association assessment. It tends to come forward to most of the health and wellbeing boards for an update. So it was good on this particular one to focus on the on children and young people. Under item 5, I do recommend, if you have a chance, to read the 2 appendices, because there is a huge amount of information in those, which I'm not going to go into in detail, because you can read it for yourself. Some of it slightly repeats itself, but that's only because it's both papers are scene setting, and it just demonstrates the changes in population, the differences in the situations of different cohorts of children, and actually I thought it was an extremely good piece of work. We had a very long session examining that and pulling that to pieces. The other thing that has been preoccupying the Health and Wellbeing Board has been the CYP mental health situation. We had a good presentation again from Vicky Jones, who's the head of transformation and commissioning, and we learned a lot about what's going on with the Waiting Well program, so called. And again, this is one which I thoroughly recommend you update yourselves on, because it makes interesting reading. Unfortunately, waiting list numbers are going up rather than down. It is a matter of concern, but this particular situation it is very much helped by being aired as it were at a joint meeting between the Integrated Care Board and ourselves as the local authority, because there's a lot of information that can be shared. So that's another one that's well worth your looking at. One of the other issues where we're working very hard at the moment is social prescribing. As you know, social prescribing involves solutions for people which aren't necessarily medical. The idea is, if anything, to avoid getting into medical solutions if Healthy Lives programs can help, rather than that. And for children and young people, the numbers again that are being treated by social prescribing are going up. It's something like in the 800s at the moment. That's a very good thing. And on that subject, it's worth mentioning, I think, the recent opening last Saturday of the new Highley Medical Centre, which is based in the Halo Leisure Centre at Highley, because that is such a good example of social prescribing, where you've got the doctor's surgery and you've got some of the solutions which social prescribing presents to people, all on the same site and in the same spot. So that is something which we're very keen to try and replicate elsewhere. It was a particularly interesting set of circumstances which brought this together and helped this happen in Highley. But it is exciting, because it means that it's opened up new ways for us to work again with our primary care partners. And we will be following up on that. We had the usual update from Claire Parker, the Director of Partnerships at the NHS. I'm pleased to say that from where we're sitting here in the council, we are having some very fruitful discussions with the ICB. There's a lot more joint working going on. Claire Parker is very much part of this. And again, I would recommend that you cast your eye over her report. Then we had a report from the Shropshire Food Poverty Alliance group. And and particularly updating on the situation with the food banks. We had short pieces on shaping places. We had an update from Penny Basin on SHIP, which is working very hard at the moment, and a bit of information on the health protection update. So it was a very full meeting. There's lots for you to have a look at in there, and I believe you've also been sent a link to the actual meeting itself. So hopefully you'll have plenty of information there. Thank you, Chair.
Thank you, Councillor Motley. Anybody have any questions? Councillor Bentley.
Thank you, Councillor Mark. Has there been any discussion? Thank you. Can I ask, has there been any discussion about the removal of the Shrewsbury and Telford Hospital NHS Trust and also the Shropshire, Telford and Wrekin Integrated Care Board from special measures? Because
no, we didn't cover that. We didn't cover that. That's not really within our remit as a health and wellbeing board. So no, that was not covered.
Because they should be look at being removed from special measures within 12 months of going into special measures, and both the Integrated Care Board and the Trust, the Shrewsbury and Telford Hospital Trust, entered special measures in July 2021 on the first day that the system went into place, and so they are the oldest organisations in special measures under the new parameters. So this should be tackled with urgency.
Well, I absolutely agree with you, Councillor Bentic. It doesn't come under the remit of the Health and Wellbeing Board, but I have to say that we do have a very good relationship with the new Chief Executive, Simon Whitehouse. He and I co-chair the Health and Wellbeing Board, and I think he is working very vigorously on this because we are very well aware that we are held back by their status. It doesn't help us at all. And as you know, we've got a Care Quality Commission assessment in adult social care coming up. And it is quite difficult for us when we're dealing with a hospital, which is a hospital trust in special measures. So we are as keen as you are to see them improve sufficiently that they have that status removed.
Thank you.
More? Councillor Kidd.
Hello, Cecilia. As you know, Bishop's Castle Hospital will be opening 12 and hopefully 16 beds in the future, and also hoped that would become much more of a hub for very rural areas.
Yeah.
Can you be assured that you will be taking that forward with the Health and Wellbeing Board, because it's really important to the Southwest?
Heather, I absolutely appreciate and applaud the amount of work that's gone on from all the residents of Bishop's Castle in order to get Bishop's Castle up and running. And I think that this is a development which is very much welcomed everywhere. It doesn't need, I think, for us to look for the Health and Wellbeing Board to look at it at the moment. But I think once it's been running, we will very much want to see how it's getting on and how it feels it's getting on as well. So we will certainly be tracking it.
There is an opportunity to do the Highly type stuff there as well, which is really why I brought it up, to hang it on the Highly part of the agenda.
Well, that's if that's the case, that's absolutely brilliant. Highly benefited from a whole lot of things coming together very well, unusually productively. And you know how long these things can take, but this was actually achieved in 2 years, Highly. And it happened because there was a mass, as far as I can make out, retirement or resignation of the existing medical team at Highly. Bridgenorth Surgeries stepped in. They put up a porter cabin temporarily. They came to an agreement with Halo that the porter cabin could go on the site at Halo, and the next step from that was Halo enthusiastically welcoming them actually into the building itself. So one has to have those ingredients, I think, to be able to replicate highly. And I'm sure that you're thinking in terms of Spark for this purpose, are you?
I'm not necessarily thinking in terms of Spark, and I was aware of exactly what went on in Highley, but there are other areas, and we don't have to wait for GPs to resign because, and I think Ruth will fill you in on that.
Chair, and thank you for Cecilia. Bishop's Castle is, I think, slightly different in that there are a number of facilities already in the hospital in the form of space and some very well-equipped clinical rooms, with changes to some of the services being offered by the GPs in the primary care network. So there's a sort of pushing an open door really to have the hub base at the hospital, which is literally 5-minute, 10-minute walk from the leisure centre. So I think the Highley model could easily be replicated on site, and it's something that the campaign group in Bishop's Castle are very keen to support as they're part of their priorities going forward. So taking that through the Health and Wellbeing Board as it develops and to keep under review would be really appreciated by the communities in the southwest of the county.
Yeah, I'm sure we can do that. Penny Basin was very active, along with Shropcom, in the whole Highley project. I'll have a word with her about it, and we'll see if we can get it onto an agenda.
Thank you.
Yeah, thank you, Chair. Thank you, Cecilia. You mentioned social prescribing, and
yes.
And it's good to hear that you're working on that area too, or hearing about that area. Just want to draw your attention to the fact of the Wen Swimming and Lifestyle Centre that you know of, that's the only charity-run pool in the county, and it introduced. We've got a very good relationship there with Louise Woolcroft. And she's doing excellent work, actually. And it did this morning. There was a community connectors meeting in Oswestry, which is going around the north of the county. So that's working very well as well. And we've introduced it at the Wen Pool since January. And I think already this is in adults, actually, not children, but we've already had an uptake of between 20 and 30. And that's gym and the swimming pool itself. So I just don't want to forget us as a non-county pool in all that's going on in the county.
Yep. Yep. Edward, I remember having discussions with you about the Wen Pool when I was doing communities and leisure. So I'm very well aware of the Wen Pool, and I applaud what you're doing. I think that's great, and that forms one of the most important parts, I think, of the whole initiative for social prescribing. So congratulations to you and Wen. Yes. And I'm sure if there's any way we can help, we will.
Yes, good. Well, one of the things that we did, it has been a helpful thing, is that we actually managed to employ a deputy manager, and he has taken the responsibility for whole that programme here. So that's been one of our encouraging steps forward by having somebody dedicated to looking after it.
That's great. Claire Sweeney is in charge of our social prescribing programme, so I'd be very happy to raise Wen with her and see if we can do more to help you.
Thank you.
Thank you, Councillor Motley. I believe you've got to go off now for another meeting.
Yes, I'm so sorry. I have to run on to another one. Thank you very much, Chair.
Thank you. Bye now. Item 8 is Local Care Services Virtual Ward and Integrated Discharge Team. Right, so we have Claire Horsfield, who's the Shropshire Community Health Trust Director, Operations and Chief AHP. Shirley Pitstock, Senior Advanced Clinical Professional, Shropshire Community Health Trust. Dr. Nazir Domun, Consultant, Shropshire Community Health Trust. Sarah Robinson, Divisional Manager, Urgent Care, Shropshire Community Health Trust. And Claire Parker, Director of Partnerships in Place, NHA Shropshire, Telford and Wrekin. And remotely should be Rachel Robinson. She's going to be here later. So who's kicking on? Oh, yeah, yeah. Should get on there where Tom is.
We just give apologies and people that have attended the centre. Claire Hinsfield sends her apologies.
Sorry, could you just pop your mic off?
Actually, you right on button? Yeah. Look, so apologies noted from Claire Horsfield and Shirley Pitstock. And in replacement, we have Andrew Bugler, who is capacity and flow manager in Shropshire. So that's the panel that you've got today. Claire's just behind us. Okay. So we'll introduce ourselves first to you, and then we will take you through the slide pack, and we have a combination of slides and videos just to demonstrate and show you the services that we're asked to talk to you today. So as you said, I'm Sarah Robinson, Division Manager for Urgent Care, supporting the delivery of the virtual ward.
Yeah. Can you just move the mic a little closer?
So I'm Andrew Bugler. I'm, as Sarah said, the manager for capacity and flow through Shropshire Community Health. I'm a nurse by background.
Good afternoon, I'm Dr. Nasir Doman. I'm the consultant for the virtual ward service.
Okay. So we're here to introduce to you firstly a virtual ward. What we thought would be really helpful for those that aren't so familiar with it, to take you through our video, which gives a description of the service and our patients that we see. So we're happy to start that, that'd be great. Has been tested.
Absolutely, I haven't worked before. Bear with me a second.
Pick the plug.
Worked perfectly in rehearsal.
Virtual ward was introduced to relieve pressure on the acute trust where possible. So where it is clinically needed, patients obviously need to be in an acute hospital bed. However, lots of patients don't need to be, and it is safe to provide care and treatment within their own home, which is why a virtual ward was introduced.
So the virtual ward is for any patient living in Shropshire, Telford and Wrekin who can be safely managed and monitored within their own environment as an alternative to admission. We have developed multiple clinical pathways which patients can be onboarded onto, such as a frailty pathway, so particularly frail or older adults above 65 years old can have an alternative to being on a traditional ward but still receive the ward-based care that they would expect to receive.
How it makes me feel as a clinician providing that care at home, it enhances my skills. Obviously patients benefit from it hugely, so you really feel like you're making a huge difference. I'm really enthused that Telford and Shropshire have embarked on the concept of virtual ward. I'm proud to be a nurse on the virtual ward in Shropshire. I fully expect it to escalate and become an even better service than it already is.
I'm Jodie Ecclestone and I'm a patient of the virtual ward. So I have a long-term disability where I don't produce white blood cells, so this makes me very prone to infections. And then sometimes tablet and oral antibiotics don't work, so I have to have IV antibiotics. Before virtual ward came along, I'd have to go into hospital and be administered these, so it's quite limiting that I'd have to spend multiple weeks being stuck in a room and on the ward.
I'm John Martin. and I'm a patient with the virtual ward. Life before the virtual ward was, in a nutshell, it was hell. I'd had about 3 months of nothing but chest infection, in which case I ended up in hospital thanks to the staff at virtual ward. I feel that I was saved.
It was life-changing, both physical and, mentally. It was life-changing. Going into hospital, it does, especially with a long-term condition as a young person, it gets quite sad and depressing. You have to stop your life and for your illness, whereas this virtual ward has enabled me to carry on.
Had it not been for the virtual ward, I would have had to have stayed in hospital. Don't know what the answer would have been back then, whether I'd be here today. To be looked after at home is so important. The staff are out of this world, and they made me feel part of what they wanted to do, and it makes me feel as if I was human, not a body in a bed. I do know that the virtual ward helped me through this. Just 2 words. Thank you.
For me to be part of this is huge. I've come from the acute trust, so I've seen the impact of being in hospital and what that can have on a patient. To actually now be part of that virtual ward process, keeping them at home, avoiding that hospital admission, or taking them from hospital and getting them back home sooner, is massively rewarding from that point of view, both personally and professionally as a trained nurse.
The future is really exciting for virtual ward as we develop more and more pathways to ensure that we can deliver care to patients in the community, whether that's intravenous IV pathways or pathways for patients with heart failure, COPD, or multiple respiratory conditions. So there's lots to do, and it's a really exciting time going forward as we develop more and more pathways for our patients.
Side. So hopefully that gives you a nice sort of overview really of the service, which is still very much in its infancy in our area. We sort of started off the service probably about 18 months nearly.
Could you speak?
Is that better?
Yeah.
So we just explained that the service is still in its infancy, so that gives you an overview and introduction of where we're at. I'm going to hand over to Dr. Dolan just to talk through start with really the virtual ward pathway and how that looks for patients coming into our service, moving through that, and what we try and aim to achieve during their stay on our virtual ward.
Hi, so that bit of a diagram there. Yeah, it's tricky to see from here, to be honest. These strong glasses. So basically, the virtual ward is a way of looking after patients at home, as opposed to the traditional hospital route. We take quite a few sick patients, so referrals come from various sources. So the ambulance service, general practice, referrals from hospitals try and reduce the length of stay, and also from care homes. So they will call in. There is a standard number that they call in. Everyone calls into the service. It is triaged by a nurse. They will decide as to whether that patient requires a response within 2 hours, and that's our urgent community response, or they can be dealt with within a different period of time, and that would enable us to put them onto the virtual ward directly. So traditionally, the general practitioner looks after the urgent community response side of things, and then if their needs are a bit more complex and they need to stay a little bit longer, we then put them onto the virtual ward. It's a bit of a misnomer, virtual ward, because, as you can see, we go to their house and everything is done. A lot of things are done face to face. We do use technology to monitor observations, to video consult patients. However, the vast majority of work, which we'll come to a bit later, is actually face to face. So we go to the patient's home and administer the appropriate treatment to them at home. So we assess them, treat them. They are discussed with one of the doctors daily. We have twice daily kind of board rounds, and we discuss the full caseload of all the different areas. So we have a service in Northwest, we have a service in Northeast, Central, Telford and Wrekin, and then we've got 2 services in the South as well. So across county, we replicate that same model to have that equality amongst the patients. So that is very important to us because we want a standardised service across the entire county. So as you can see this, it happens every day. We ensure that we are, it's just like on a ward, there's a check. Have we done all the things that we need to do for this patient today? The patient also has the added advantage of being at home, so they can get on with some of the activities they normally would do, which reduces their deconditioning. It reduces the risk of hospital-acquired infection. So lots of positives to that. Also, the family can visit, family can come round, they can help. It's a big difference, as you heard in some of those patient stories, to the patients themselves. Should we move on to the next slide? So obviously we do medication reviews, reduce medication. There's lots of things we do for each of the patients. These are our current pathways, and probably don't need to get stuck down in the details, but we can do a lot of things at home now. So we can do intravenous antibiotics for patients. We can do intravenous diuretics, so medications to treat heart failure. We can do oxygen at home. So there's lots of things we can do that traditionally you would expect from the hospital only. Okay, so these are, so anyone over the age of 18 is suitable, in inverted commas, for the virtual ward. However, what we find from evidence is these cohorts of patients mentioned here would be more benefit to this group of patients. So the vast majority is the frailer older adult, and particularly if that older adult requires assistance to get out of the house to do the higher level activities of daily living. So these patients, a lot of the evidence suggests they're far better off at home than they are going to hospital. So we also have a lot of patients that kind of are in that kind of last year of life or last 2 years of life. And again, the evidence shows that if you can help keep these patients at home, it is far better for the patient. So I think that's probably what that slide is trying to tell us, but don't need to go too much into the details. I think, yeah. So do you want to?
Yeah, so I mean, that gives. Oh, sure.
Yeah. Right. So,
Can I ask questions as we go along?
of course. Yeah. Yes. Please.
If I may, could you just explain more about the any care home resident? Do you differentiate between people in a nursing-based care home or residential, and any sort of impact on the staff in those services, and particularly around patients who find admission distressing, such as people with learning disabilities? When you complete an intervention, is there any impact on the staff, perhaps in supported living for people with learning disability, and having to pick up some of that work that would normally have been happening in a hospital?
Yeah, I understand. Yeah, so there's no differentiation between the care home resident, nursing or residential. However, we will provide a lot more support to a residential home than we would from a nursing home. Similarly, we would go more often and help more in those in assisted living, supported living. So we may increase or utilise the council services depending on what area of the council we are, the county we're at, to increase the package of care. Sometimes we bring some of the patients across to being in a kind of care home environment if we felt they weren't able to manage at home for that period of time, for that acute illness. And when that episode of care was over, we bring it back home. So we have to do it as safely and as timely and as effectively as possible.
I think just to add in relation to the care home residents, particularly residential and nursing, and the difference between them, we've been working quite a lot with Shropshire Partners in Care, because obviously if you've got that nursing element, you have qualified nurses within that provider potentially. And it's how you support as the virtual ward team in reaching for that team and support their nurses that are there. So it's this sort of working relationship that's been developed, I think, really in line with what their staff can do. Because as you say, that might be above their skill set in certain care homes, which is why our team would go in to support that resident during that time.
just as a follow up on that, Peggy, rather than.
Sorry, Heather, could you pop your microphone on, please?
I'm really concerned that actually we know there's a real dearth of carers out there. We're having a tremendous amount of problem recruiting. So if you have a residential home that actually needs extra carers, and they're not always available, then presumably these patients can't stay in a residential home because they need a better package, and we can't provide that package at that point. They would have to go into hospital, because there is a significant need for carers out there, and it's a stress on our system at Shropshire Council. So I'm interested in what you would do if those carers for an extra package for somebody who needed it on a virtual ward in a residential home.
I think it's a different case by case basis, isn't it? Essentially, we are working with Shropshire Council. Natalie's here, or she's on the screen now, isn't she? She was. Around how actually additional care requirements are sort of matched with virtual ward, because obviously we're the health service delivering that, and there is an impact potentially for the level of dependency of patients and care required, and that's part of by the admission affordance services currently. But within a care home residence, if their needs can't be met within that care environment, with our health team, there will be a decision if it's the right place to stay at this moment in time, as you say, because you can't put that extra pressure on those care homes if that's not appropriate.
It'd be useful to see those numbers at some point.
Yeah.
I'll come back with a learning disability question. So a number of people with learning disability, adults with learning disability, are supported by the council in shared lives or in supported living through direct payments. If they need extra packages of care, how is that funded if they're on a fixed budget from the council, either individual service fund or direct?
I don't think some of those answers are there yet. That's something we've got to work with the council. So if we're looking at additional care, those cases are managed through the social workers that are allocated. So it's almost a review on that basis. So we don't have additional funding from the councils at this moment in time to provide the adult social care side.
I think that's something I'd be concerned about, because you have a fixed direct payment budget, you suddenly need extra support. How does that get paid for? But I'm supportive of people with a learning disability being supported at home as long as possible, because it is very distressing.
Not really, that covers a broad spectrum of people,
yes,
isn't it?
It does.
Older person, young person, and those really.
But there is quite a drive in the
Yeah.
council to have those people on individual budgets so that they're managing their own services. But I'm concerned that if that level of need escalates, how that would be funded.
I'm fairly sure that has around that support we've got from the RCB about what that commissioning is and what does that look like as a system around how we put in the needs, because people aren't that simple, are they? So they manage their health needs but don't have social care needs. So how does that all come together within a holistic plan of care? I think those are the things going forward that still need to be out.
We have Roy next.
Yes, if I can. About the old problem of weekends, bank holidays and out of hours responses. What happens if it all goes wrong and a patient needs assistance out of hours?
So can I answer this council's question first, then we'll go on. So regarding the social services aspect, we use the standard kind of admission avoidance pathway. Now, when you look at care, if you can provide the care earlier and avoid the hospital admission, the patient becomes less dependent. Therefore, bringing the intervention here often results in less care needs on this side of the equation. From the discussion we've had with the social services, our clinical services manager has had, they have seen no significant increase in their workload. And they're well aware that actually that's what I explained will be the case going forward, because that will help you reduce the care needs. However, there are individual cases where things don't work out the way they should. However, the vast majority, it does work and it does help keep that patient at home without significant increased stress and burdens.
I think we were responding to the statement was made, we were responding to the statement that was made, which was actually they may need a different care package or better? So that's why we were asking questions around that, because you raised it.
I think it's the definition of care package, isn't it? I suppose holistic care includes everything. We've got to consider all those bits to what that looks like. And we're accessing, as Mal says, all the services that are available already to complement that for that episode of care for that patient. Come back to you weekends.
So the service runs 7 days a week, 12.5 hours a day. The out of hours provision is provided by Shrop Doc. So yes, so if there are issues on the weekend, we have a doctor on the weekend as well. So we have either a very senior GP or a consultant cover over the weekend as well. And the staffing is equal over the weekend and the weekday. So there's lots of staff. So the patient knows who to contact that, and out of hours as well, they know the numbers to contact. There is obviously, yes, it's commissioned for 12.5 hours a day. So there are issues that could happen overnight. But again, having looked at the data, there isn't too many, admissions overnight or problems overnight where they haven't been able to deal with them by the standard services.
Right, can I come back on that one? I'm just wondering how many patients you've got in your virtual wards at the moment, because further down the document it says that 8% of patients are readmitted within 30 days. I just wonder what 8% represents in numbers and actual people.
So what we've got there, the total number of referrals there, that's something we've seen in 18 months. So currently we have about 105 on the virtual wards of patients. The average length of stay is 14 days, but it's probably a little bit less than that because of the way things are reported. So let's say it's 14 days. So 8% is very good. So the NHS England target is 10 to 20%. So you need to take a certain amount of patients that are relative. They're on the cusp. They're close to being in the hospital. If you can get in, you can sort them out. So that is a very good readmission rate. I think the SAT readmission rate is around that as well. So that's quite good because the level of patient we're taking isn't far off the hospital level, and often it is a hospital level. So if you're looking at bed day savings, NHS England expect one virtual ward day to be 0.6 of a hospital day. From the analysis I've done with my team, we are managing to do 0.8. So we're taking sicker patients. And that is why our length of stay is a little bit longer than other places, but we're trying to keep them out of the hospital. So we're not doing too badly on that front.
Okay. Thank you. Thank you.
Ed?
Thanks, Chair.
Thanks, Chair. I think most of my points have been covered by other councillors, particularly around social care. But the one thing I just wanted to raise was around, particularly in rural areas, elderly, frail people who might not have support networks around them, isolated, or family not living nearby. How does that factor in? Because a lot of elderly people, when they're not in hospital, rely on either family assistance or care package or neighbours to support them. But of course, in sort of some areas of Shropshire, we have a lot of elderly people who live very isolated, who might struggle in this scenario.
Yeah, so agreed is the answer to that. So what happens is we obviously assess the patient as to whether they are suitable to remain at home. Now, we do have access to those admission avoidance packages of care. If we can't get them that, then the next step would be to try for one of the community hospitals. And if we couldn't do that, then obviously, as a last resort, acute hospital. So we will try our best to access those packages of care via START, etc., for them and additional support. And we'll always try and provide that additional support. And obviously, the clinicians will make a decision after discussion with the multidisciplinary team as to whether that is the correct thing for the patient. Because sometimes the right thing is for the patient to go to hospital. So we assess that obviously case by case basis, and that sort of rural area, we do find sometimes it is hard to get a care package to there. And sometimes they'll say, no, we will not be able to do that. And then obviously we can't compromise that patient's care, so we have to look for an alternative pathway.
Yes, thank you for answering that Gerard's question. So I was going to ask the same one. Thank you. Just getting to practicality for me. We're doing 2 visits a day or whatever. And who's monitoring this? Where's all this information? Is it going back to a central person? Is somebody sitting behind a screen, or is there all data comes in watching what's actually happening, like ward sister would, or something like that? And I presume because there's distance involved, travelling time, you'll need more staff for this to work.
Okay, so to answer the first part of the question, the visits are determined by clinical need. So some of our antibiotic pathways are 3 times a day. Some of them, they're not having intravenous antibiotics, but they still need lots of visits. So it depends. Sometimes you might not get a visit a day, you might get a phone call or a video consultation. So it just depends. So we play it, and every day, every patient or most of the patients are reviewed in some way by a senior clinician. So often it's me. So they will check in with me at any time. They can call me now if they want or they need me, or if they want me to go and do a visit, I can go and do a visit. So it's like on a hospital ward, everything is being checked daily. Now, we have a coordinator that coordinates across the county the services, but we've got teams, as mentioned, in various, so 6 teams across the county, and each team will like have the equivalent of a ward sister or ward manager that looks after that caseload. So each nurse is assigned so many patients. So yeah, so in fact the staffing is not probably, it's not that much more than a ward would have, to be totally honest, and the 105 patients currently looked after by the equivalent of 3 doctors, which is less than you'd have for 105 in the hospital. We've got 4 advanced clinical practitioners coming on board in the next few weeks to months, so that'll give us a little bit more medical minded cover as well, so it gives us additional strength in our workforce. We currently have about 55, 60 odd staff across the county, which I don't think for 105 patients is, extra massively more than what you'd have in a hospital environment. Yes, you are correct. As a house visits, you would have to have a few more staff, but we are more efficient doing it this way.
Okay.
Julia?
I think it was the same question. I couldn't see how it's more efficient if time is spent travelling. Previously that team is in one location dealing with the people in the same place. So some of their time every day is now spent on the road seeing the same number of patients. So I see that you save money on a building, capital costs and overheads and running, but I don't see how that is fewer staff time to cover the same number of patients where you have to now include travel. Can't quite work
So that they are located in their locality teams, so there is no additional travel. So we've got sites in all the areas.
So if one location is the south, that's the south of Shropshire, so that's a distance of 50 miles.
We've got 2 locations.
Southeast of Shropshire, that's a distance of 30 miles. So that,
there is
obviously
distance. Rurality is an issue.
I live in the southeast of Shropshire, so I'm telling you it's 30 miles. So obviously that's more time than if we're in the same room, isn't it? For each visit, for each patient. So I'm struggling to work out how that's more efficient. I don't quite understand the.
I don't know if it's an efficient. I think it is just the geography and the location. So all teams, whether it be community nurses, community therapists, and virtual ward teams, they are set in a base, and there will always be a geography going out from that base. But what
if I'm just comparing it to a physical ward, there wouldn't be travel.
No.
Just comparing.
No, yeah, you're right.
A virtual ward in someone's home, we're comparing it to as if it were a ward in a hospital.
So it doesn't compare like
exactly.
So I think what we're trying to describe is how we can make it most efficient, because that service was asked to deliver at home. It wasn't asked to deliver in a ward. So based on our ward is the patient's home, our teams could be centralised, but that wouldn't be efficient. So they've been put as your point. So I think we've missed your point. So we're not comparing like for like. We've put our teams in the locality, neighbourhood teams, so they can be as close as possible to the patient and in our buildings that exist.
To reduce that travel time.
Yeah, but equally still there is still significant travel time even from those bases in reality.
Yeah.
I think the other thing to appreciate is you've got everyone co-located in a hospital, Okay, but it's quality time spent. So is that nurse always with the patient? You know, they are monitoring, but are they doing something? So when we go and see the patient, all of that visit is spent doing intervention continuously with the patient. Yes, I agree, there is some travelling time, but I would say, looking at our staffing model and how many bed days that have been spent on virtual ward and saved from the acute trust, I don't think we're costing, certainly not costing anywhere near as much as the equivalent hospital beds. Yeah, and in terms of interventions and things we're doing, so I think what we do is more pragmatic treatments. So we might not monitor as closely, but actually it doesn't alter the management of that patient. So doing a lot of tests sometimes doesn't yield a change in the management. So I think that's what I mean. We're efficient in that we're pragmatic and we do what is required to aid that patient.
What about healthcare assistants then? Presumably, in order to get their homes up to a hygienic standard in terms of, you know, medical interventions and to be left until the next visit, presumably there's also a requirement to have some healthcare visitors, perhaps equipment, or to do some cleaning to make sure that that's not a risk.
So teams carry their equipment, and we do have healthcare assistants. So we do have people that will help the nurses do observations, take bloods, prepare things, so cleaning. So we bring our equipment and obviously we clean them in accordance to the NHS guidelines and trust guide policy, infection control. So it's standardised practice across the country.
Perhaps you're alluding to, can the patient look after themselves in their home during that period of illness? Maybe, and our healthcare assistants are there to support in those low-level tasks.
It's a bit more than that. It's exactly that, the environment. My dad was looked after at home for the last 2 years of his life, and my mum and the healthcare assistant spent a lot of time making sure there was no infection every time he was recatheterised. So that meant lots of cleaning, lots of materials, lots of things being replaced. You know, that's quite a lot of work. You can't just go into everybody's home and assume you can immediately start giving injections. So there must be that preparation to make sure that it's appropriate.
Yeah, so it's a combination, isn't it, from the qualified nurses that will give the instruction, and the support team of the healthcare assistants can do that. But we still have really strong links with our other existing services. We still have community nursing, community therapists. So we wouldn't just, you know, if you're well known to your district nursing service for a chronic condition, we wouldn't just suddenly, you know, remove that person from the care. It's around working who's best to provide that care, who knows that patient best, and then a combined effort, because there will be others, and including adult social care and the voluntary sectors who are already really involved with these people. And that's something that probably will need to evolve and get stronger as we go forward, because we've already talked earlier, social prescribing. All these things almost need to be bolted together to help a person during that phase, and then recovery time after. And actually what Mal said earlier is that preventative element as well, because it's always a balance, isn't it, between someone's journey and their health.
So that's okay. Bernie, I think you were next.
Thank you.
Yeah. Okay.
Thank you, Doctor. Is it Damon?
Dermot.
I think we're all convinced that there are benefits of the virtual ward, and certainly patients do prefer it if it's possible. But in terms of cost, you may be aware that there's a study from Greater Manchester which found the cost of virtual wards being twice that of a hospital bed at £1,077 per day compared with £536. So it's twice as expensive. But that's not to say it shouldn't happen. But there are other aspects. The first is that in February, the virtual ward system was under capacity. That is, that it wasn't operating at full capacity. And so can you advise whether it's now at full capacity and what the plans are in the immediate and long term, or even medium term, to go forward with expanding the capacity? The other question I was going to ask was in relation to the recording of information, and in particular consultations, because if in the 8% of cases it does go, it does require admission or referral back to the A&E department, then clearly it's essential that the A&E department have the case records and the observations that have been done in the virtual ward. And can you reassure us that those consultations and recordings are available to the A&E staff, which clearly they should be in an integrated care system. I think that was mainly what I was going to say. And finally, liaising with urgent care out of hours. How does that happen? And just finally, can you confirm that the virtual wards are still under the aegis of Shrewsbury Telford Hospital rather than the community? Because I think that originally they were under the care of the acute trust. Is that correct?
And it was commissioned, the provider is Shropshire Community Health.
Thank you. Thank you for so a lot of questions.
With obviously our providers, particularly SAP from developing pathways.
Yeah, and that's a big thing. We have to work with all the system partners to try and get that capacity up to what is expected or predicted by NHS England to be the capacity of the service. We're currently trying to be at 145 patients.
So that's your capacity?
Yes.
So you're running at 2/3?
Yeah.
Can you say why?
So I think this is a different way of working. It's a new-ish service, and it takes a long time for people to utilise the service. So we have to create that trust within the system, within all the healthcare providers. And I feel that I work in a hospital as well as in the community. I feel that what we need to do is, which we've been trying to do, is advertise the service, get more and more people. So it's a work in progress to utilise the service. So we've gone around different system partners, discussed, make posters, working through those issues, why they felt that hospital admission was more suitable over the virtual ward. So sometimes also the patient, they will go to A&E. And I think sometimes when people get into the system, it's quite hard to pull them out. So once you're in a bed, then people really find it difficult to discharge a patient back out. So we are, as I say, it's work in progress. We're working with all system partners to try and increase that referral into this service and direct referral, and that's why it's one number that they call, and it will get triaged and appropriately assigned to the appropriate clinician. So that's your first question, isn't it?
Just to add then, as I think there's been significant work done in the last few months, hasn't there? Particularly the medical director for SAF, supporting their consultant, the A&E consultant, and working through what those pathways look like and how we can safely manage their patients. I think primary care have done lots of work, haven't we? At their PCN meetings, there's been joint information provided to really get that assurance. And I think the latest sort of that EMIS work that's been done around sharing that patient record is helping that communication, because we know historically that IT talking one system to another, is still not there, is it, in the world that we live in? So we've been making definite progress around, particularly for primary care, significantly at the moment, improving that aspect, and then that helps sort of build on those people's confidence to refer. The pathways also are quite new on board, aren't they? So respiratory and heart failure, quite new, working with the lead cardiology consultant, respiratory consultants in SAF to try and do some other step out of hospital services. So I think we're attacking it in lots of different areas of where we think we can do that. And sort of West Midlands Ambulance Service as well is another sort of important aspect that we haven't mentioned really, where we're working with their validation teams around patients in that pre-hospital sort of moment.
And questions about the observations and the consultations being available to the A&E staff when the patient arrives electronically.
So unfortunately, as Sarah mentioned, the systems do not communicate very well currently. We are working in getting that. However, if a patient of ours needs to go to the emergency department or any service really, we'll write them a letter with all the details, interventions that we've done, and that will be emailed to the appropriate service. But also a physical copy will go to the patient with them, so at least there is that fail-safe there. On discharge as well, we do a discharge letter like in hospital as well. So that goes to the GP, the patient, and the acute service that may have referred them.
Sorry to interrupt, but of course, the time that the patient's going to go to A&E is 12 hours that you're not there.
Yes, however, they will be.
How does the information get to the?
So we will look at if any of our patients have gone in, and we will provide that information in the morning. Now, they will usually have contacted the. They usually would have contacted the out of hours shop doc service, and shop doc also will make a communication if they have assessed that patient.
So the shop doc had access to that information that's been gained from the consultations during the day.
I think no, they don't, and the same as primary care. So if I go into hospital today, they don't get from my GP why I'm being admitted. We're still in reality in a process that we haven't achieved that. So we've got some distance in data, but as you say, in daytime hours we've got access to that between primary care and ourselves. But that hasn't been achieved, and that's got to be part of sort of the digital transformation and IT solutions that we're still working on. So for being honest, no, we can't. It would depend on, like you say, if they've gone through care coordination, there would be that link there. If we speak to their GP, we link there, but there's not an electronic instant alert, let's say, for.
But there is, of course, ENIS information.
Yes.
And you could link with ENIS quite easily.
We're working on.
We're working on that currently. That's just literally a new addition to the service in the last month.
Yeah. But also, I think, you would have the out of hours, the information would still only be, that's the problem, they'd have to seek the advice of a healthcare practitioner out of hours for the information to be transferred across, because it wouldn't automatically go, see, because the hospital don't get EMIS. They can't access EMIS in the hospital. We can have access a summary care record, but that is not detailed enough. So for us to make the decision, we'll have to make decisions based on what we see in front of us. So that's the reality of the situation at the moment.
But I can access my own information. I can access my own information on ES, including all of their health data. And so it should be quite straightforward to designate somebody to be able to interrogate that system.
It's a summary of your information. However, we're talking about more detailed medical information, more detailed medical things that would not be included in that. And currently, unfortunately, those systems do not talk to each other well enough or share information well enough to do that. So we do work slightly with one hand tied behind our back, but I'm sure there is a strategy in place to try and link all these systems together from the ICB point of view.
I'm sure you get my drift.
Yeah.
And there are tangible results. I mean, I've looked today at the data for March 2024, and the number of hospital patients remaining per day has dropped significantly, down from about 150 to between 100 and 120 a day. So something's happening that's positive, which is great. Yeah.
I mean, there's no doubt, isn't there? There's still things to do, and we recognise it. So we'll take all your points on, we'll take it back to our programme to make sure we're done.
I think that the other thing to mention is it can't be costing more than the hospital bed. I think in some regards, that is, but not in Shropshire. This is the thing. There's a big difference in the way Manchester funds its service compared to here. So I think it would be good to look at the local numbers and see. But I'm very confident that we're a lot better value for money than a hospital bed.
And it'd be great to see the data.
Right, Heather and Ruth. I don't know which one of you was first.
Thank you. Right, NHS England. I know it said you opted into it. Well, NHS England actually said we would all do virtual wards, and it was a one size fits all actually at that point. And it was never going to work in the way NHS England thought in very rural counties and very rural areas. So I would like to know what you have done differently to make it fit. What is it that you've said? Because some of what you've said I still don't think fits the 200 square miles of the rural southwest very easily. So what have you done differently to make this work? The problem in the rural southwest is, but certainly my parts of my division, we're 35, 40 miles from Ludlow. And access for a GP or anybody is up single track roads on hillsides. So it takes more than 40 minutes. It will take you an hour or more to get to many of those places because they're very remote, just as Ed was saying. So there are real issues around that. Because our locality, I believe, is Ludlow, it really does not serve the rest of us, but everybody is fixated with putting things in bigger towns, which don't necessarily serve the areas well because they're a long way away. The Ludlow locality fits really well for that bit around it. When you start going into the Shropshire Hills and across, it doesn't fit at all. So there are issues around that, which is why we're asking questions about the hub and Bishop's Castle. So I'm really interested in how you rural proof that, because on top of all of that, you might say, oh, well, the doctor could do something digitally. Actually, the broadband and the mobile phone signal is shocking. So there's which most of you will know. So you can't do that digitally. That does mean there are greater costs for our rural areas because of all of those really difficult issues to deal with. So it's not just about saying about Shropshire, it's actually about looking at the costings across Shropshire, because it's easy to do something much cheaper when you're talking about the middle of Bridgnorth, or you're talking about Shrewsbury, or you're talking about Oswestry, or even Market Drayton, or somewhere a bit bigger. Once you start going into the countryside with shocking roads, I might say, where you'll find that your carers are smashing up their cars, because my carers coming out into my division are smashing up their cars, there is a whole different cost base to this. So what I would like to see out of this eventually is, one, how you're doing it differently, two, how the costs are allocated across different areas, three, how many in the rural areas actually work, because one of those other problems that we've seen is that many of these people who would do well from a virtual ward, because I'm not anti them, I'm just telling you there are some significant issues, their home is just not up to it. I've had two whom they wanted to release into their home, which were quite frankly shocking. In a shocking state, so they couldn't go there. So they need other forms of beds or a care home or whatever to get better in before they could go home. And how, with my experience of release from hospital, how secure are you in the multi-agency teams releasing people from hospital? Because I've had several instances where people should never have been released home without support. And I've got another one that I'm watching carefully at the moment, because her husband's been put into a hospice. They're both in their 80s, and she has had an operation. And last time this happened, she was released home with no care at all. So there are a number of things here where she would actually really be living in a good quality home with value being in a virtual ward. It's not happened for her. And I'm desperate that it doesn't, she's not left there in her 80s again on her own with no hospital package.
So, to answer the first part of the question, this service is different to a lot of the virtual wards across the country, in that we do a lot more house visits than other service. If you can't, as you mentioned, I mean, even Telford, the signal's awful. So it's not just in rural areas. Telford, the signal's awful as well. So, and what we are finding is, as mentioned, we will not keep a patient we feel is unsafe at home in that environment. That is not what we're here for. We're here to safely look after the patients that can be looked after in their own home environment at home. Sometimes a patient says, no, I'm not going to hospital because they've had such issues. And we'll try our best then to put in any intervention. So that's how this is different. It's not a one-side. In terms, I used to work in the rapid response team, community services in Dudley, Dudley's a lot smaller. It's completely different. So whatever I learned from there,
It's smaller but bigger.
more population, but as I say, it's a smaller geographical area. And you cannot see, we were all based in one place and it just doesn't work. So that's why we, as you mentioned, we're trying to kind of refine that. And actually, we've got one of our doctors that works down in the Ludlow area as well. So it's
no good to us.
But you can, they can get out there and visit. So I think it's about. So he's a bit disappointed that patient hasn't been referred if they could be suitable, and we're working on that. That's a very hard sell because you're changing the mindset of the healthcare professionals.
And the multi-agency team.
Yeah. So all of the team, all of the team members. So I think about, and again, package of care and these things that the discharges from the acute trust. We can't comment really on that. However, we are finding there are deficiencies in that. So we try our utmost to support the patient as best possible, because often they'll say, I don't want to go back there.
So as a add-on, as a scrutiny committee, we're here to make things better. So what can we do to make the virtual wards work better? So far, I've heard the IT systems need to talk to one of which they've never have, and SAP is now having a new IT system, so it's an ideal opportunity to join them up, I would have thought. But is it going to happen? So there's a whole bit around IT system, but there's also a whole bit around training and referrals, because otherwise they're going to bypass you.
No, I think it's a fair point, and I think the workforce is something that we'll have to review as well, given that we were only given an infinite amount of money to set up the service in its infancy, and with the rural geography, what you can do with a number of people in Ludlow, based between Church Stretton and Craven Arms, would give us the best bet to get to people going one way to Bishop's Castle and one way up, towards Ludlow and beyond. We know,
or Worthing and Shrewsbury.
Yes, exactly. So we know that geographically from our teams that work there, know that the number of people they will be able to see will be less because of the travel time. And so we do that as efficient as we can based in the locations we've got. But ultimately, if you want to scale it up in point of time, so the whole of your population for your area can be seen at home where it's appropriate, we will potentially need to be looking at how many staff that needs to look like, because only so many people can get so far with the visits required.
Can I just dive in there? Just out of interest, you obviously got compartmentalised the county. So I should imagine my division falls into the central Shrewsbury area, yet I border Heather, which will be in the southwest.
Yeah.
If, for example, when you have people admitted, is there any flexibility? For example, if you had a cluster of people in my area come in under central, but a few miles up the road, you had a few people in Worthing, that falls into southwest. Is the flexibility to allow the teams to be efficient in their travel and say, right, because we've got people here.
Absolutely.
Yeah.
When it was first set up, it was, set by our GPs, the profiles and the PCNs. But actually now we've centralised the triage. It's about a sensible approach. Who's best to attend that patient first? Who's got the capacity to do it? If you're right on a border, doesn't really matter where the map goes. And if you're a central team or just nipped over into the south team, we will look at who's the best person to respond on that day to that individual. So there's no,
And how do you work with those with doctors over the border in Wales, as I have?
Fortunately, the service is only commissioned for Shropshire, Telford and Wrekin.
I am a Shropshire resident.
Yeah. So it's where your GP is, unfortunately. It's not GP registered.
Die on my own then.
No, there are services across the board.
No, not like this.
Not the same. Not the same. However, they're
if I need social care, it's not provided by Wales. It's provided by England.
Yeah. So there have been questions like this and patients like this. So the other day we had a patient that was registered to a Ludlow in inverted commas GP. No, apologies. The patient lived in Ludlow but they were registered to a GP practice outside of the county. So it was a Worcester GP. And I asked them to use the service. They said, well, it's health. They're registered to the GP here. We'll see them. Then the following day, they said, no, we can't see them too far away. So in that instance, we made a decision to see that patient because it came in our geographical catchment area, and there are obviously cross-charge arrangements regarding those patients.
And that would have been, so I think we obviously have Claire will probably jump in. So, you know, the patients, like there's the commissioning side of it and who your GP is, but actually on a practical day-to-day basis, we would be looking, as Al's saying, who's the patient, where do they live, having those discussions with that area GP and who's best to provide that service, and then we would go to the ICB to advise them.
Most of my services are in Shropshire, but my GP is 3 miles away in Wales.
And those are the types of cases where we'll be saying, actually, can we do that cross working?
One of the age-old conundrums, of course, is that the local authorities work on resident population and health works. Sorry?
Could you speak a bit louder?
Well, somebody's asking me to speak louder. Blimey. So one of the age-old conundrums is that local authorities work on resident populations and health work on registrant populations, irrespective of where you live, which is, it doesn't matter whether you're across the border in Wales or you're in different counties in England, that has long been an issue. However, I actually went to an event with Powys on Monday, and we have started having that conversation about let's work across the border with Wales and work out actually how does integration work for you guys? How do we manage those patients along that border? So we've got lots of meetings. I've got lots of meetings in the next couple of weeks to look at how we do that quickly. So what are the quick things we can do, and then what are some of the longer term things that we will do?
There you go, Heather.
I've only been doing this for many years, so thank you.
Yes, but sometimes people don't do the obvious, like and have a conversation with somebody that lives in Wales. I think the other issue, of course, is that NHS England, the clues in the title, it's the virtual ward bit, and we have the same bit when the ambulances are queuing outside Shrewsbury Hospital, that actually NHS England do not look at the Welsh Ambulance Service and what's happening and what we're triaging around that either. So that gives us an additional challenge, shall we say. So the virtual ward element, which from a commissioning perspective was really, really challenging because, as you rightly point out, a one size fits all model does not work in Shropshire. It absolutely does not. There is some pragmatism that we have to develop, and I think we tried to fit the NHS England model in to start with, it's fair to say, and I think it's only now that we're really going, or over the last sort of 12 months, that we've really gone, actually, how does this work best for the residents of Shropshire? I think there is some pragmatism that we have to look at around the clinicians that are supporting the services, because obviously they've got to be based somewhere, and with, you know, as much as we'd love to put them in your village, I know you don't. I'm
quite pragmatic myself.
So I think sort of thinking that through, but I think it'd be really, really helpful to work through with you all about your different patches and actually what you think might be beneficial for your residents. Actually, what might that look like? So I would recommend that as sort of liaising with you as elected members to look at your individual areas. I think that would be good to do.
I think the other issue with this, my GP may be in Wales, and half my village is, and half of my division have their GP in Wales, but the problems are the A&Es in England.
Yes.
So actually working together is a very pragmatic thing to do. Yes. Because if we don't do that, half my village, if they need urgent care, will end up at A&E, which we don't want. And we actually want to give a better service, and social care has to provide for us and not over the border. So finding a way through that is fundamental for both the Clun division, my division, and further up, and Bishop's Castle division. It's a fundamental issue.
And that's the conversation that we've had about. So Wales are looking at having things like the CDCs, the diagnostic centres, and actually having a cross-border arrangement so that people along the border, if you're in Westbury or Clun or further north, you can just travel over and go and use the Paris CDCs, and the information will come back as well.
A Welsh pub would be great.
Yes. Yes, so we're looking at those integrated. But I actually cancelled a meeting with one of the colleagues in Powers today to come here. So, but we've got it back in next week, so don't worry. So, but I think I think it's really important that we do have those conversations. So.
Can I just chip in there, because I think that's really positive.
Yeah.
Because I think both of us, possibly four or five of us, will have properties that can only be accessed from Wales. So, for example, their bins are collected by Powys Council because Shropshire, it would make no sense for Shropshire. So it's brilliant that health and those conversations are happening. I think I don't want this all to sound negative, and I felt that's been a little bit negative, but I think most people would want to be in their own home. So I think that's really a really good thing. And I think our messaging is, you know, our rurality, particularly for us that are rural, is a big concern, and those on the border is a big concern. And I'm really pleased to hear that those conversations are happening, because it's felt like in health particularly for a long time that hasn't been happening.
Yeah.
And if it is now, I'm really, really pleased about that.
I live in rural Shropshire, so that's why I'm interested in this. Yes, it is really key, and there will be some compromises that we will have to make. But you're absolutely right that the point about this is being person-centred, and actually what is right for that person, and that kind of review and looking at whether a person, I don't say the word patient, but a person is appropriate to be seen in their own home has got to be best thing for them. And the other bit about the travel is, it's the patient is in the acute trust, that might be right for them, but then the family doing the visiting, if they're coming down from Bishop's Castle and trying to, you know, traverse, depending on what time of year it is, that also has an impact on the family in that situation, and they might be coming from further afield as well. So we're just trying to bear all of that in mind when we're just thinking about the rurality.
Right. Ruth and Gerald, and then I'm going to ask it, because we've only got on the first bit of the presentation. I've just realised.
Thank you, Chair. You've mentioned throughout the conversation, which has been positive, I have to say, about sort of some targets about readmission, bed day saving. My question is, do you have a suite of indicators or key performance indicators? And will those be available at some point for Scrutiny to review? And have you had to adjust any for the, you know, being pragmatic for addressing a rural area? You know, NHS England accepting of those, or if that whole sort of question? I mean, you know, you've given us a little bit of taste here of average length of stay and 8% patients or electric, but I'm particularly interested in seeing a sort of dashboard and how that's improving over time or not. Okay, maybe.
I think most certainly that will develop into wanting a lot more detail beneath that. So we've got very quite, you know, broad spectrum KPIs, some of those like referrals, occupancy, length of stay. But I think what we'll start to need to look at, won't it, will be the profiling of, you know, the age of the patients on the service, how long are they on, what are the conditions we're treating, some of the clinical conditions. So I think that's going to be the next sort of way moving forward. Really, we're working with the ICB that are doing lots of data collection to so sort of having a single point and looking at all that metrics measure. That's sort of led, isn't it, Claire, by the analysts there. So we're trying to look at all that because it actually relates to the next picture. So both those people in hospital, those at home, and so this journey of patients, rather than just seemingly looking at a service, because it's actually linked to other things and how that impacts. So I think absolutely we will.
Well, the short answer, Ruth, is yes, we do have a suite of metrics. The next question is, what is that telling us, and how much further do we analyse it so that actually we can start with improve it, which is what Sarah's then talking about, the profile. So we do have a performance report. I will speak to Julie Garside, who's the Manager of Planning and Performance, and seeing what we could share with Scrutiny, because that would be really, really helpful. But actually, some of the questions that you raised then will inform the information that we need to raise through that. So yes, but we need to kind of develop that, and again with your help, I think that would be really good.
Thank you. Gerald, do you have a question?
Can I say I'm most impressed with what you've achieved so far? I think it's excellent. But I just wonder now, do you have any contact with volunteers who might be able to help next door neighbour, or maybe somebody close by who would pop in for reminder of tablets or shopping or things like that, which should help people out?
So just extra to the virtual ward, we're doing a lot of work around the communities and neighbourhoods, and actually working with the community and voluntary sector and the volunteers. And we've actually today we did a One Shropshire event. I know Paula couldn't make it, but actually it was around the voluntary community sector and how many hours they're delivering in support services around some of the integrated projects that we're doing. So the answer is yes, we're doing more. We need to capture it. We need to make sure the voluntary sector is sustainable, but we're working on those thriving communities, but it kind of sits outside the virtual ward, which is very clinician based.
And do you have any electronic phone calls or maybe electronic monitors, particular ones that you're not happy with? So to remind them to take tablets or things like that?
Those things I use, but it's a long time since Natalie might be able to answer that more from a social care perspective and a modern technology perspective. So I'm sorry, I don't have the information about that.
We've got pharmacy team attached to the virtual ward. Also, the nurses and other healthcare providers are very good at kind of prompting the patient, maybe putting the medications out and putting notifications or alarms on the phones.
Yeah.
So they will think about that. But also, just to mention, this is a bolt-on to all the other services that are available as well. So it's all about tapping into what's already there and using it to its full potential.
Right. So working both ways.
Yeah, definitely.
Natalie, what to answer?
Hi, thank you. Yeah, just to add from a social care perspective, we do always try and identify opportunities for assistive technology. There's a lot of good work in this space with partners, so we can look at it collectively. And as part of a multidisciplinary response, it's not always appropriate for everybody, but it can be, sometimes people prefer assistive technology that can help with prompts and things like that rather than more people coming into their homes. So just wanted to add on to that from a multidisciplinary perspective, across health and social care, we can look at assistive technology as part of an overall package to support people.
Thank you, Natalie. Very quick, because they want to go on with the rest of it.
Well, I'm not sure whether this is the next thing or the last one, but of those who leave after an average of 14 days, are most of those step downs? And how does that work, given the difficult relationship with primary care that you've referred to?
Yeah.
Or have I misunderstood?
Our relationship with primary care has got a lot better because it, as I say, it was a new service that was put in, one size fits all, as people have alluded to. You're doing this, virtual wards. So we've developed that now relationship with primary care. They know where their remit ends and where ours begins, and the hospital are also in that area now. They know where their remit begins, and obviously there is some overlap. There has to be to ensure no one slips through the gaps. So we are building those relationships and building those things. And as I say, it's probably that we in the hospital don't let the patient kind of go early enough. And again, that's getting looked at from their side. And again, about referrals in from the ambulance, referrals in from the GPs or primary care. That kind of why are they going for 999 when they've got this service? Why are they going? So slowly we'll build it there.
On discharge from the virtual ward, it's the traditional pieces of paper which somebody has to get to the GP.
So then
is that how it works?
Electronically the discharge summary. However, we do give the patient a physical copy.
But I think you said a summary was a summary. So really, if the GP is going to take over responsibility for the medication or whatever, he needs the details.
Yeah, they do. That's what they get. It's like a hospital discharge summary. So essentially the same information that the GP would get from a hospital discharge is on our discharge summary.
So, sorry, being slightly cynical, nothing has changed over the last 10, 20 years. It's still bits of paper being handed about.
No, it's called the discharge summary just because you can't give the whole medical record back to the GP, but it is electronically transferred from the virtual ward to the GP with all the medication information, what stopped and started, any medical interventions, what the diagnosis was. So that from the virtual ward does go back directly to the GP. So there's probably a better interface between that step down. There's also step up opportunities from primary care into the virtual ward as well. So that also happens. So I would say that has improved in the last 10 to 20 years. I would like to have the beauty of that bit, yes.
Well, all our case notes are electronic. In principle, on the virtual wards, they're all electronic notes. And if the GP does want additional information, we're more than happy to provide that, or someone else, even the patient, they can access their details via the usual channels. And also, I think we were alluding to step up and step down. It's a tricky one because a lot of it started to step down, but we're seeing more and more step up. So it varies month by month. So currently we're probably looking at it's about 60% as a step down, and 40% as a step up.
I think interestingly,
It's going to pull them now because you've got this one, this one.
Yeah.
No, I was just going to say, interestingly, from the GP's perspective, recently, in fact, they've actually been saying to us they can see more opportunities to use us in a better way, particularly with their sort of new recruits around paramedics in practices and other allied health professionals working alongside the GP. So actually, that might support us more.
Yeah.
The rest of your reports. Oh, sorry.
It's a stop check. It's outlines have feeder discussion is during the work.
There's actually
we've probably covered quite a lot.
Yeah.
We've read it in advance, and then I think we've just wrote questions.
Yeah. I think the last few
So we
slides.
apologise for that. We get carried away sometimes.
Enthusiastic.
Enthusiastic, yeah.
So we've gone on to the integrated discharge team. Do you want to do that then?
Happy for us to do that? Yeah.
Yeah.
Yeah. Okay, so is that wrong? So that's just an introduction slide. So the integrated discharge team, just to give sort of a summary of that service. Historically, the discharge team has been led by the acute hospital. And about 18 months ago, there was a drive from the system to look at the change in leadership and to support from a community trust perspective and to look at complex discharge from the acute hospital setting. So that strategic priority was put as a high important piece of work to be undertaken. So Shropshire took over leadership of the complex discharge team in SAP, co-located with half the team that is employed by the acute hospital and our community and therapists and assessors from Shropshire Community Health Trust, and co-locating in two bases, one at PRH and one at RSH hospitals, with our local authority adult social care teams, including Telford and Wrekin and Shropshire Council. So in principle, we've just put a little diagram there around really what the ambition, around the teams that are involved, including our virtual ward, which we've just talked about in quite a lot of detail around how that supports patients discharging from hospital, the complex discharge team, and the principles of discharge to assess models, our community flow teams, which are supporting that in and out of hospital services across all types of community health services, and care navigation around sort of our triage function into all our different community pathways. So this is again a very new and infancy service, I suppose, with lots of historical challenges, shall we say, around how that's delivered, joint working, collaborative care, and where we are at now. So what we have is a whole multidisciplinary team with service leads, staff around different expertise. So we have, although not so many therapists now, but do we just change from recruitment? So the ambition is to have an MDT encompassing nurses, therapists and support teams with a really comprehensive background of understanding discharge, both from community services, adult social care services, those that work within the care sector and care homes. So that when we're looking at patients and supporting patients that are in hospital, around getting their journey to leave hospital as timely as we can and to provide the best service when they leave. We've already heard, and we hear every day still, obviously, difficult situations where people haven't left hospital with the right care and support that they need. And I'm absolutely sure we are not there yet, but this team is actually what we want to achieve. And I know many of us in this room have probably involved very much, even in your life previously, around integrated intermediate care, complex discharge. It still remains quite a complicated and sort of multifactorial and using a huge amount of services aligned to get patients out. So the team as such is set up, again, quite a long process of recruitment, because we started with a very small team with a high level of investment. So we've been working that through to the, and that takes time, particularly in Shropshire, to attract new staff. And if you do attract them, you move them potentially from different areas. So you tend to end up with different resourcing issues and different services. And our teams have been set out in, I can't even see that from here, but we have separate teams that are supporting with flow functions, with assessment, with administration functions, and sort of more metrics and measures and performance. So that sort of just gives you an idea of the team's approach. It was because we were conscious of time and we were just doing a brief update of our IDT. We just put some of the key achievements that as a team we feel are really important to recognise. And I think the biggest one from a staff perspective to start with was a change and shift in the culture and acceptance of joint working within the hospitals. It was no doubt, and the teams will tell us that when we started working in the hospital, there was lots of anxiety between staff about whose job, whose role, whose responsibility, and how we were going to move forward together. And we have now got, I would say, on the whole, really shared purpose, really shared values and experience with the acute hospital teams across operations, therapy, and social care. And I think we have absolutely moved mountains, it feels like, from a professional perspective over the last 12 months. Still work to be done. You're never there. Recruitment has been a challenge for us, although we have recruited 19 staff to date, which is no mean feat to get the right people with the right skills, which was really important. Because we have been repeatedly recruiting, but that doesn't mean to say we appoint to people that just for that purpose only. So we have attracted and taken people from actually the adult social care teams, which has probably caused issues on the other, on our other side. But actually, it's about working together, and so actually bringing those people in together will ultimately help us to understand what we're doing right for our patients. Some of the sort of metrics wise, and we have, again, and we can perhaps speak to Claire about bringing those forward, have a whole suite of measures that are being collected around our patients who no longer should stay in a hospital. So those are classed as no criteria to reside under the framework that we're working towards. And obviously, as we've talked about, pretty much what we've talked about, virtual ward, keeping people out, we don't want to keep people in hospital any longer unless we know all the risks. And I don't need to tell anybody here what those look like for our patients, and particularly those that are older. So the key ambitions for the team, with lots of sort of interdependencies about how you get somebody out of hospital, would be to focus our identification of people earlier in their hospital journey, on admission, understand what their needs are, both socially, their health, what that means for the person to be able to leave hospital, and to monitor those people on their journey through hospital and plan to get you home at the right time, and to squeeze that time in that delay to reduce that as small as possible. So our baseline for patients with no criteria cited discharge was sitting around 5.5 days over just about 2 years ago. And at best performance recently, last 3 months, we were around to 2.5 days. But taking off 2 to 3 days of someone's stay in hospital when they shouldn't have already been there because we'd already recognise that they don't need to be in that acute hospital bed anymore. And of course, you get lots of benefits from that, which all relate to the whole other conversations that we've been having. The MDT approach, we've been working around the documentation that we're using and trying to share that as a shared document. There's still more work to be done in getting that to be utilised across all partners that are involved in the patient's care, from the patient themselves to our care homes, to our other services. That's ongoing work. Again, a little bit about policies and how we can share those policies across organisations so that actually everybody's working to the same principles and guidance.
Just say MDT, what does that?
Oh, a multidisciplinary team. So
just for anybody listening.
Yeah. So multidisciplinary. So that's bringing in all our colleagues together. And really, and now we're sort of moving to a set-up service to trying to embed that as business as usual. But that now brings with it all actually what do we want to achieve and what do we need to do to try and improve things. Amber's here to support us with one of the nurse by background, with a community background, a ward manager through community hospitals and community services, about how we can influence the understanding of acute hospital staff about what is available for their patients to get them home. So that's
Thank you. I think that's really interesting. And I may be reading this incorrectly, but on the graph with the coloured boxes on and the team 4, the purple box, one of your KPIs is we've got 2 of them: reduction in discharges before 10, reduction in discharges before 12. Don't you want an earlier discharge in the day? The earlier the better in the day.
Yeah.
Usually. So why is that indicated?
I need to check that's correct. So obviously we want more people to go home by 10.
Exactly.
I think it's to improve it to where it's at the moment. So I can't remember the wording on there. It might be
reduction in discharges before 10.
I think it's it's definitely the time. So reduction in. So it's making sure that more patients are going before 10 o'clock and before 12 o'clock.
If it's a slight okay. We need to change what it says then. So you're absolutely right.
Earlier in the day.
Yeah, absolutely. And some of those mechanisms aren't at the moment in control of our team. We're working with staff because we've got all the factors that the acute ward teams are managing around getting people ready to transport, all the things that we know.
Earlier in the day.
But early in the day, absolutely important. Yeah. Late at night is absolutely not what we need to do, not when we should be planning.
Thank you. I started my journey with Shropshire Council and healthcare matters on ambulance waiting times. Tom, behind you, remember all that? Actually, so I used to take it and see you are reducing the need. Well, beds are becoming more available. There's bed blocking taking place because you're reducing the. If they can get out of hospital quick for the right package, you've just been saying. I've just got a case of a gentleman I'm dealing with who's very, very ill, going to hospital. In fact, I'll probably go and see him on the way home tonight. Been bedbound for a long time. There's lots of care from Shropshire, but he had to wait in an ambulance, and he was number 7, and he was getting service in the ambulance. That's still going on, so that's still an issue, and therefore there's still work to be done. But one word I've not mentioned, heard mentioned this afternoon. Maybe I'm not getting it right, and maybe I don't understand properly, but you haven't mentioned mental health teams, because I have a big issue in my area, like we all do probably, with people who have mental health problems, and they lead on to clinical problems of that nature that you've been talking about. But I've got one that bounces in and out of hospital at the moment. He's very near, well, I would say almost dying, to be honest, but he gets recovered a bit in hospital and then sent home without the right package in the network, and then he's back in again, and I just don't know where that ends, to be honest. But you have, I suppose you're going to have a connection with mental health teams, and there's another body of people dealing with all that, and that's another group you're integrating with in this virtual ward and things.
Yeah, so particularly for the integrated discharge team, Midlands Partnership Foundation Trust obviously provide the mental health support for those patients in the acute hospital, and so they are based on site. We'll be working with them in parallel for patients that are obviously known to their services or referred to their service. So they're not based and co-located with us. I think you're right, there's probably some more work to be done to get that connection with them, and access to their information is kept separately again, so we're back to the IT solutions. But they are involved quite closely for patients where they're referred with dual, physical and mental health.
Julia?
Yeah, I wanted to understand the payment side. Is it still the case that when the patient's discharged from hospital to the social care team, that the first 6 weeks is still paid? And then from then, okay, you know, how does the funding transfer?
So obviously, Ashley might want to come in more specifically around the reablement and offer. Don't know, do you want me to, would you like to answer that?
Natalie, would you like to answer
Yellow.
that one?
Hi, yes, thank you. So in relation to reablement, for people that are having a period of reablement, that's free, but their long-term ongoing needs, they'll be financially assessed. Sometimes there's a little bit of a myth that it's 6 weeks, but actually it's the period of reablement that people can have. Sometimes people can be reabled in a week, 2 weeks. It depends on the needs that they present with, but that tends to be the case for reablement. Lots of different funding sources depending on what pathway you leave hospital under, but for reablement, that's the position. Thank you.
What we've been trying to work on really hard with the sort of reablement philosophy to aim to get people home wherever possible is to sort of try and change the language that we're using. So like what matters to me, so what matters to the patient, what are their goals, how the therapist will, what do they look like, both from your physical goals, your mental health goals, your social goals, your emotional goals. So it's quite complicated in a hospital to do that, but people will have a set goal of what they need to be able to leave the hospital, and then that can be looked at in the community to take them further. So we're trying to get that working together so that we can then meet with our psychosocial colleagues.
Right. Yeah.
Sorry, Jen, if you
Talking about discharges.
Yes.
Pharmacies.
Yeah.
Now, the biggest holder up of discharges in both our hospitals, and right up to the present moment, I mean, this has been going on for years. I don't know what the system is for the ward to inform the pharmacy that certain drugs are required, but somebody wants to look at that. If you want to get your patients out first thing in the morning, then you're not going to do it unless the pharmacies start playing a bit better than they do.
And I think that's Claire will come in here, but I think that's the sort of he was talking about where we're, how do we get all these things to come together to help us do that?
Yeah. Do I need a Janelle mitt?
I'm a pharmacist, don't you? Okay, I think so. There are some slow bits of pharmacy getting what's called TTOs to take home medicines, but you have to wait for the discharge letter to be done by the usually the junior doctor on the ward to do that. We've done quite a lot of work with SAF, and actually SAF have done a lot of internal work themselves in trying to improve those processes, and they have improved actually. One of the biggest challenges that we are finding at the moment, and again, certainly the ICB, housing, health and public health have come together to talk about housing, is actually making sure that people can go home with the right adaptations. And actually we've been looking at some case studies around that. So whilst I'm not denying that occasionally pharmacy might delay things, it's at the end of a chain of a number of things, and they do keep ward stock of basic medicines as well. Thing for me that I would like to mention is discharge planning the day that a patient is admitted, and what that day of discharge is and what is needed, and that comes into the housing, the medication and the information that goes out to the GP need to be started at the earliest opportunity. And I think there's a little bit of work, sorry to the doctor on my left, but a little bit of work with the some of the clinicians in the trust. No,
I'm not actually. So the reality is, it's not planned as well. It should be called discharge planning for a reason. So I do feel that there's that kind of, it's done too late, and that's why it always comes down to the pharmacy, because that's the last thing that you get. But actually, as you say, it is a chain, and if any link of that chain is not in place, then you kind of lose the entirety of it. So I do agree that, and it is education to the staff on the wards that yes, we are aiming and having those kind of performance indicators to say before 12, before 10, gives them that kind of onus as well. I often send, if I've got enough junior staff, that is, I often send one to, we'll see the sick patients first, deal with them, and the next step is the ones we can discharge, so we'll get them doing the discharge summaries if they haven't been done the day before. So then we can get that process in order. But as I say, it's a mindset thing. That's not the way people worked or work, but they need to work that way because of the strain and the pressures of the system. So they need to be a lot more savvy in the way they utilize their time and the time in the day they're doing the things. So you're quite right, yes, but I don't think it's just pharmacy. I'll take responsibility because a lot of it is medical as well. So as I say, as the consultants, as being the kind of the coordinator of that kind of episode of care, and the responsible clinician, we need to be more proactive at kind of focusing on the plan as they come through the front door again and back out safely.
Thank you, Chair.
I'm not sure if it's you or
I think it's myself.
It's you.
Thank you for that. I retired from staff in 2018, and ever since I worked there, it was the same problem about discharge letters. This is an administrative task. Why are you giving it to junior doctors? That's the first thing. The second thing is that for the system to work, there needs to be an MDT in the same way as there are for other aspects of care, a discharge MDT, so that the system works. We keep hearing that.
What's an MDT?
Sorry, multidisciplinary team, and so the working of people together for a common purpose, which is to discharge appropriately, has been there for many years, in fact, decades, if not longer. But we still hear the same thing. And so what's going to change so it will happen? And that's my first one. The second thing is the topic of mental health came up. And of course, if you have been to NA departments, as I have on many occasions, some of the people there that are most distressed and that are causing the most distress for other people are those with acute mental health problems. Yes. So why isn't there a virtual ward for mental health?
Onto your first point. I think you're right. Many of us worked across this system, and discharge has not been able to seem to move forward and improve as much as we would like it to. I think where we're at now, the difference that we're trying to achieve is that multidisciplinary approach on the ward level with staff that come from the community and adult social care that understand what is available to get people out of hospital. Now, in the 20 years I've worked both in Shropshire community and the hospital, we have not been able to achieve that. We've had periods of it, but that support on the wards directly to work with ward rounds, consultants, therapists hasn't been there. Now, I would say that's the change we're aiming for, which appears to be influencing some of the improvements that we've seen. But it is, I think, a small step in what is quite a huge, complex situation and complex patients. So I think you're right, we're still absolutely not there. But I think some changes in both the understanding and from the operational teams for SAMP, the flow teams and the MD, the multidisciplinary teams on the ward is helpful. There's definitely more steps to work with the consultants, both across medicine and surgery and orthopaedics. We've got really good buy-in from the orthopaedic team actually, that we met with quite recently about how they think they can do things differently. So there does feel a change in that engagement, but I think it is not going to certainly happen overnight.
And with regard to giving these administrative tasks to junior doctors, I think that's a pejorative term, but it's a term we use, who are under incredible pressure to do lots of things, and we're giving them administrative tasks that others could do, and take them away from clinical care. Why is it still happening in the 21st century?
I mean, I don't want to answer the question because I'm not a staff employee, so I think we would perhaps ask that you may know because you do dual role, but whether that's a question that would be for staff themselves, I wouldn't.
I think the thing is you need a prescriber to do the discharge summary, that because it is a prescription at the end of the day. So
you can get that done in advance, can you?
Oh, yeah, sure.
So that
And
aspect
that's why I
we
kind
get
of, yeah, oh, I agree with you fully. And that's what we try and make sure that it's all done. But as I say, it is a problem, and you say it's been a problem a long time, and it has. And we seem, so we're trying moving forward.
But you see what I'm getting at?
No, of course we see what you're getting at.
I mean, from a Shropshire perspective, I think from your perspective, we're now looking at medical secretaries to support you, digital letters, aren't we? So that was something that we want to look at internally in our organisation to help clinicians do what they need to do, and not do admin. That question to the acute hospital perhaps is something that needs to be raised at.
Both.
Yes.
Heather, last question for you.
Right. I'm glad we recognise that actually discharge isn't just about care, because it isn't. Part of it is care, and I'm glad we also recognise that it's very complex within the hospital, because actually discharge of weekends is much slower than it is the rest of the week. There are a whole range of things around that, including the fact that we still don't have 24/7 care within the hospital, which would actually make a fundamental difference, but costs a lot of money. And which is why presumably we haven't got there. And I have asked Gareth several times about this from the ICP, as you would expect me to. But there are still some areas that really concern me about discharge, because I had a gentleman, the occupational therapists of a multidisciplinary team will ask somebody if their home is heated, and they actually take what they say as the truth. So when you ask a gentleman in his 80s who is not liking being in hospital, actually wants to get out, if his home is heated, and he says yes, but he doesn't tell you it's a wood burner and he has to get wood for walking down the A488, and you discharge him home on New Year's Day, then that is not a safe discharge. So what will we put in place to make sure that occupational therapists do not believe, because that's not the only case I've had, and that was the most shocking, because actually his house was disgusting as well. He was being released home to a house that really wasn't fit to be living in. But, and when I rang the ward sister and said, please don't send him home, she said, I've got to get rid of him. So, but the occupational therapist was key to this. She believed what he said.
Yeah. So, I mean, I think that's a reasonable challenge to any professional about professional curiosity and making sure that what you're doing is appropriate. I do have slightly separate to that. I do have an issue when a patient has capacity to make a bad decision. They should be allowed to do that. You know, there is still, if it's person centered,
yes.
Well, you know, people make bad decisions every day, and actually there is something about not allowing somebody to go home that could be called, you know, deprivation of liberty without it being under capacity. I'm not suggesting, Heather, that this is in relation to that.
I think because he had a history of actually having to be discharged into some form of rehabilitation, but then actually there was a case here where maybe that shouldn't have happened. Yeah. And he was a difficult old so-and-so, and when finally care arrived, he was also racist. Didn't help. No. But anyway.
So I think, and again, I just pick up, we've just had 2 workshop sessions around housing and health, and actually, again, I picked up an issue around some of the OT, occupational therapy support in the acute, what happens in the community and what happens through social care, and actually how things are signed off. Again, going back to adaptations, whether it's a warm home, what's appropriate and how we get that checked. And there were so many quick solutions. So we've got a meeting set up with the housing support, the private housing, David Gregg from Shropshire Council, myself and Penny, to start and look at how do we bring some of these things together. So actually there's a discharge process that's really smooth, that can be signed off quickly, which benefits the patient foremost, or the person foremost, because it's person centered and gets them back into a warm and suitable home. it benefits the acute trust because they're getting a patient out of the bed safely, and it benefits social care because they haven't got to sort out temporary accommodation, you know, a bigger care package. It's appropriate for that individual. So we can take that away and have a look at that as well as part of that kind of integration approach to neighbourhoods.
Just to pick up the point where we have made some improvements. So obviously we've had an acute hospital team, and we now have a community trust team working alongside. So joining up using our Rio system. So we're now able to support the hospital who couldn't have seen before what we were doing for someone in the community. So they were known, we can say, potentially for that prisoner being seen, what's been happening before, when were they last seen, what were the issues. We've also got Shropshire Council colleagues and health colleagues from on site. They equally, although different system, they're there in the building and we know which patients we're working with. So we can do some of those background checks. So yes, the comprehensive assessment needs to happen and ask the right questions to get to the bottom of how do you leave your house rather than I just leave my house. But then actually, can we find any detail underneath it, which either the patient has forgotten to tell us or didn't want to tell us, that will help us make a bit of a safer plan. Still happens, absolutely, but we're trying to find other solutions to get as much info as we can to make it a safer.
There are sometimes they refer to the community team for a check. So when the patient's discharged home, one of the community therapists will go out and see the patient and ensure that what they've said tallies when they do a house visit. And similarly, those higher risk discharges, we ask them to refer to the virtual ward, because then at least someone will, we know then someone will go out and have a look and see and have a safety net. So it's a work in progress, yeah, and it is. Patient often will tell you what they think they want you to hear, so they can get home. And yeah, it is about if they got that capacity, or is there something we're not sure about or doubting that we need to do a little bit more digging.
It would have been helpful if somebody would have listened to me, because I have pictures I could have sent them what he was going back to.
And that's the thing, isn't it? It's about getting all of those informations from various sources and utilising it to make the best decision for that person, isn't it? And of course, listening to relatives, friends, people that are involved with that person. It's very
You're
important.
elected member who you have to be trusted.
And I'll be quiet. I said big thank you to you all. Hope that hasn't been too onerous. Everybody firing at me. But really big thank you today. Really appreciate it.
Thank you.
Personally, I think that virtual board sounds excellent. You know, that people I'm in the north in the church. You know, the big north, Ford, Cheshire, Wrexham and Stafford, so I get 3 lots of them. But I do know a lot of people do like to be in their own homes because they feel comfortable there. So, you know,
And we don't mind to challenge because that's what makes us get better. We will literally have this all written down and it will be part of what we're trying to do to move forward.
So thank you very much.
Thank you for inviting us and asking us some questions so that we can make things better for our people in Shropshire. Thank you.
Thank you.
Your time.
It's not your juniors doing this job. Yeah.
We're working on. We've got dictation, so it's all virtual. We have got dictation software that'll write it down for you as well. So
Yeah, but if you're saying the delay is the junior doctor, then it's still a problem.
yeah. I've got
Bernie,
the
will you let him
problem.
go
They're
when he
working
wants to
for
talk to you?
no trust.
Thank you.
Thank you. Over to you, Rachel.
Can you all hear me okay?
Yeah, we can.
Yeah, thank you. So apologies that I'm not in the room with you. I've been at the ICB board today. I've got the next item on the agenda, I believe, is the rural proofing report, which has been brought here. This was the report that was taken to Cabinet on the 17th of January. We had a good discussion at Cabinet around the report, and this is the first committee we've been able to bring that back to. The rural proofing report obviously summarises the actions that Shropshire Council will be taking forward from that was requested from this committee for Shropshire Council to take forward from that report, prioritising 5 actions within the next 6 to 12 months and then a number of other actions after that. So the report's brought here to confirm with yourselves as a committee the timescales for the reporting back. I think the discussion was to report back in every 6 months. to check that you're comfortable with the way that we're reporting. So the updates that we're giving, which are a combination of updates, process measures, as well as obviously looking at some of those outcomes that the committee will want to see brought forward. Just to confirm to committee and give you some assurance that this, obviously, firstly, this is, whilst I'm bringing the report forward, we recognise that this is a report which all of the council and obviously members will need to be involved in taking forward the actions in the report, and that we are working on it currently. So it's not sitting on a shelf somewhere. Already since the cabinet meeting, there is updates that, in terms of some of those actions. For example, on the first action, where we focused on rurality and the accessibility factors and making sure it was a key consideration. Public Health have already used the report to, as we did in the briefing that we shared with you in February, to assess our own services using the public health part of the report, to understand where we are meeting the recommendations and where we need to do more work, and we're building that into our annual action plan. Continuing, we did say that we would take this work through to the digital inclusion network, and the meeting in 2 weeks' time that will be discussed. And then also the recommendation about marchers and making sure that that report that has been prioritised, that has been recommended, and I expect that to become part of the manifesto. So just to reassure committee that we are continuing to move with the actions in this report, and to confirm the timescales to bring this back, which fits into the next item on the work programme. I'll pause there.
Thank you, and yes, the timescales are really important. So thank you. I'm interested in that we are making, as a council, a number of cuts at the present time, and there are up to 300 redundancies ongoing. How that might affect both social care and public health and so on, and how we're rural proofing that so that it is across. It doesn't, we don't lose the very staff that are in the rural areas rather than just in the more urban areas of Shropshire, because there are huge risks at the moment when we're offering redundancy to 300 people. And who picks that up, and how we spread those services after that has happened.
Yeah, so I think in terms of the impact of the medium-term financial strategy on rurality, there is obviously going to be a quality impact assessment that will be done, that we've done the initial staging of that. I would expect that to be picked up through part of that work. But you're right, Heather, sorry, Councillor Kidd, we need to absolutely make sure that we take we need to absolutely make sure that we take account of continuing to recognise rurality in the services that we provide, and we don't lose, that we maintain that rural focus in what we do, but we will be monitoring that through that equality impact assessment work. It's absolutely critical through that, and I guess that's part of in the public health piece that I was talking about in terms of why we're partially meeting some of those. We're acutely aware of the inequalities and making sure that we maintain some of those services that we provide, and looking for funding to make sure we're able to maintain that. Some of that is might not be related to the medium-term financial strategy, but it's a really important part of what we continue to do. So I guess that's part of the assurance through that piece of work, and part of the monitoring that we're doing. And we've said in terms of the public health work, we'll continue to monitor that as part of our work programme, and I'd expect that to be a council-wide as well.
Thank you. That is reassuring, because as soon as the 300 redundancies were announced, it popped into my head, how are we going to rural proof this? So yes, thank you, that's useful.
Anybody else got any questions for Rachel? No, not this time. Feel free.
Thank you. Do you want me to pick up the work programme as well?
Yes. Yes. Apparently so.
Thank you. So I guess just in terms of the work programming, there was an ask, and I guess we won't get into all the discussion here in the meeting, was to start to bring forward some of those topics that the committee had been discussing that you would want to consider on your future work programming. The focus was asked to be around the transformation work. So what are we doing as a council around transformation that links to this committee's agenda? And also within this committee, there is, as members know, really strong links to the Health and Wellbeing Board, to Joint HOSC, and Health Watch. And to reassure members that both the chair and vice chair of this committee meet with the chairs, both chairs of the Health and Wellbeing Board, with Health Watch, with myself, with Sophie, to ensure that we're aligning all of those agendas, that we are aware of topics that have been identified by members, by our needs assessments, by patients through Health Watch, and that we're bringing those forward to make sure we're picking them up in the relevant committees or in the relevant board. So we've been meeting regularly every couple of months to make sure that we've got that alignment. So the topics that I'm going to suggest now and that the committee would want to consider are aligned to that piece. So we've not done it in isolation. So there's a range of topics that the committee may want to consider. Obviously mental health and young people in conjunction with the Overview and Scrutiny Committee for People. I know there's some joint work in that's been discussed at Health and Wellbeing Board. I think there's further work that Scrutiny may want to do on that particular agenda. In terms of transformation, we've heard about local care programme, particularly in relation to virtual ward. Today you've had that conversation. There's a next stage around the neighbourhood working One Shropshire, which is linked to our transformation programme as well. And that's a topic that the committee may wish to consider. Primary care access has been really important for this committee, and it's been this committee that's driven that rather than joint task for obviously the reasons of it's very specific to place, so Shropshire or Telford separately. We'd like to continue to bring the public health report. We've brought it through a briefing session successfully to this committee, so you're aware of those key issues and any of those trends that we might want to pick up outside of it. Obviously, the rural proofing updates, which we said we'd bring routinely, would be part of the work programme. The equality impact assessment that I've just mentioned on the MTFS, I think there's obviously a role for this committee because it includes health impact assessment within that. And then there's other areas that in future that the committee may want to consider beyond this work programming session. Prevention. Are we doing what we said as a system, as an organisation, to really shift towards prevention? Dental access. Housing and health that's been mentioned, are we following through on some of those actions? And then suggestions around, and we can do this again through a briefing section, those monitoring, those outcomes that we are monitoring through the Shropshire Plan, through our transformation work, and at a Shropshire Place through the Health and Wellbeing Board, are we delivering against those? And where are those particular gaps? So making sure you've got that oversight around some of those areas. So there's quite a lot that I've run through. I've dropped it into a document that I can circulate to members to consider. Probably I'll take your leadership around that outside of the committee, but just to be clear, that's aligned to the transformation work and also that piece of joint work we do with HOSC and joint HOSC Health and Wellbeing Board to make sure that we align and we don't duplicate and we have the right papers going to the right committees. I'll pause there.
Bernie?
Thank you, Rachel. With the continuing and indeed not improving statistics for the urgent healthcare services, my thoughts and the thoughts of many are that this should be of priority. In the last quarter and all the way up till March of 2023-24, only 50% of SATH patients were seen in the A&E department within 4 hours. And it's one of the worst in the country, and it remains one of the worst in the country. There doesn't seem to be much that's improving it, and it needs urgent action because it is the worst. People are dying because there are statistics that show that people die and their condition deteriorates if they're waiting in the A&E department, particularly if it's overcrowded, for 5 hours or more. So there are unnecessary deaths.
Absolutely. So in response to your question, that absolutely needs to be an urgent priority and looked at. In terms of where I suggest that would be picked up, I would suggest that's a joint HOSC issue because it's system wide. So that piece of work where I was talking about aligning, that currently is on the joint HOSC agenda. And I guess, again, for the joint HOSC to agree that priority work programme, I would suggest for the reasons you said it remains on there. But that's a system-wide priority, and therefore what I've tried to do in the suggestions I've made to this committee is look at those ones for Shropshire Place, recognising it obviously impacts on the Shropshire population, but we would address it through the joint HOSC is my suggestion on that. I haven't presented here the joint HOSC suggestion.
Sophie just wants to do something.
It's just because the way the agendas work, the joint HOSC update was due to be prior to this for this item. So urgent emergency care was looked at by the joint HOSC on the 27th of February and on the 8th of March. Due to circumstances, there wasn't enough attendance, unfortunately, of NHS colleagues at the first meeting. So a second meeting was requested as soon as possible because of the concerns of the committee around the areas that you've outlined. And
my suggestion would be that I probably email now the joint HOSC update to the committee just because of time, but within there, it does go through the evidence that's been heard, the actions that have been taken, and also the future work programme for the joint HOSC around that area, that it is going to be a continued point of focus for them.
If I can just come back though for a second, I was at that joint HOSC meeting, and the joint chairs declined to take forward the idea of KPIs, key performance indices, for the acute healthcare services, and so we've got a joint HOSC an unwillingness to look at the problem in the detail that needs to improve the situation.
You came to the first one, not the second one. The second one was different, and actually we got quite a lot of extra information, and we're still apparently what we didn't know until that second meeting, that actually there's a whole load of death rate information around the ambulance service as well, and their late pickups that actually also needs to be included in all of that, and we've asked for that to be fed through, have we not? So that was part of that work, and it is ongoing, it's not finished. So actually we asked for a whole lot of information to come because we had the second meeting, and they actually turned up. Even then we didn't have everybody. We got the report.
Joe, if you wanted to ask something.
Yes, just I thought future fit would have been the answer to all this. Is this still going? Is future fit still going? And
yes.
If so, where are we with it?
Half of it.
That's the kind of thing that would. That's the kind of thing that would have thought of this out, I believe.
Did you hear that, Rachel?
Sorry, I think future fit. I think again, I would suggest the hospital transformation programme absolutely would be a joint HOSC agenda item. I think what would probably be helpful is if we share some of the work that's going on, and I'm very happy to share. I know as we're sharing the health and wellbeing board agenda, we could probably share that sheet that tries to triangulate what's joint HOSC are looking at, what health and wellbeing board, and what this committee would want to consider as well, and maybe if we do that outside given time, and happy to bring that back to share, because there's obviously quite a lot of topics to cover, both from transformation and the health and care system. But what we've tried to do with obviously is think what joint HOSC where it's Shropshire, Telford and Wrekin wide, and people might want to look at it from that perspective. So I would absolutely, that's something the joint HOSC would want to, I would suggest, consider.
What did happen to Future Fit?
It's called, yeah, it's the hospital transformation programme. It's become what is now known as the hospital transformation programme.
When are we due a report on that?
So
it's called the transformation programme now, Gerald.
Right.
So
and I can just confirm again, because it, as Rachel has stated, because it's a system level affecting both Shropshire Council and Telford and Wrekin Council, that is on the joint HOSCs.
Will we have a report?
Work programme information.
Joint HOSC will be having a report on it.
They will.
We'll get to know about.
They will, yes. That'll be shared back through these updates.
Thank you.
Members have been invited to briefings. And it's on all of our systems.
Yeah, I think that's coming up in the next week or two. I think we can get the dates around.
Okay. Rachel, I'm aware you've got to shoot off. I think everybody's had their questions, so thank you very much.
Thank you. We'll make sure we circulate the sort of draft topics for everybody to consider, and happy to work with committee around that. Thank you very much. Apologies for not being there with you all.
Okay.
Thank you.
Sophie.
So as I said, I think I'd make the suggestion that the update from the joint HOSC is emailed to you all. It's ready to go, so I'll be with you either this evening or first thing tomorrow morning. Just conscious of time, but that contains some more information around the urgent emergency care and the topics that have been discussed already. Just so you know, the next meeting of that is the 16th of May.
9th of May.
9th of May.
For the joint HOSC.
Oh,
sorry. No, I'm not doing your job, Chair. Sorry, no. Joint HOSC is the 16th of May. Thank you.
So the work programme we've covered, haven't we? So the date of next meeting is the 9th of May, which is on the rise of the annual council meeting. Well, thank you all for attending.